Good day, doctors. This afternoon we shall be tackling arterial and venous diseases. I only tackle the more common ones, and the surgical details, which are fellowship level, are not discussed in this presentation. Since the vascular system involves every organ system in our body, the symptoms of vascular disease are as varied as those encountered in any medical specialty. Appropriate history should be focused based on the presenting symptoms related to the vascular system. Pertinent questions that need to be asked are shown here in this table. So basically just a history of the comorbidities and history of previous MI or anginal episodes, as well as tobacco use. Specific vascular examination should include abdominal aortic palpation, carotid artery examination, pulse examination of the lower extremity, such as the femoral, popliteal, posterior tibial, and the dorsalis pedis pulses. There is increasing interest in the use of the ankle brachial index or ABI to evaluate patients at risk for cardiovascular events. Normal value is usually greater than 1, and patients with an ABI of less than zero point 0.9 correlates with an increased risk of myocardial infarction and indicates significant underlying peripheral vascular disease. An ABI of zero point 0.5 to zero point 0.7 usually is seen in patients who experience claudication, and those with zero point 0.3 to zero point 0.5 ABI patients already experience rest pain. An ABI of less than zero point 0.3 is seen in patients with gangrene. So basically, the ABI is determined by measuring the blood pressure in both upper extremities, and the highest systolic BP is used as the denominator. The ankle pressure is also determined using a BP cuff above the ankle and measuring the return to flow of the posterior tibial and dorsalis pedis arteries. So the ratio of the systolic pressure divided by the highest arm systolic pressure is the ankle brachial index. Ultrasound examination with Doppler analysis can suggest atherosclerotic occlusive disease if the waveforms in the insonated arteries are biphasic, monophasic, or asymmetrical. CT angiography is a non-invasive contrast-dependent method for imaging the arterial system with sensitivity, specificity, and accuracy that rivals that of invasive angiography. MR angiography is basically just similar to MRI, but its advantage is that it does not require contrast. The contrast used, if ever, is gadolinium based, and this is not nephrotoxic. Diagnostic angiography is still the gold standard in vascular imaging, but its use is decreasing nowadays due to the higher sensitivity and specificity of non-invasive procedures such as CT and MR angiography. So now we proceed to arterial diseases. Your book mentions the six arterial diseases, and we shall tackle each of this one by one. Atherosclerotic occlusive plaque is by far the most common pathology seen in carotid artery bifurcation. plaque formation is complex, beginning with uh, intimal injury, platelet deposition, smooth muscle cell proliferation, fibroplasia, and luminal narrowing. Approximately 85% of strokes are ischemic due to hypoperfusion from the arterial occlusion or to decreased flow from proximal arterial stenosis, as well as poor collateral network. The common causes of ischemic strokes are cardiogenic emboli, carotid artery disease, lacunar infarct miscellaneous in 10% of cases, and 15% of cases are idiopathic. Duplex ultrasonography is the most widely used screening tool to evaluate for atherosclerotic plaque and stenosis for extracranial carotid artery. The table here shows the criteria of reading ICA, internal carotid artery stenosis, according to the luminal diameter reduction. So it's deemed mild if less than 50% occlusion, moderate for 50 to 69%, and severe stenosis for 70% and above. Conventionally, patients with carotid bifurcation occlusive disease or CBOD are divided into two broad categories. Number one is patients without prior history of ipsilateral stroke or TIA, and two, those with prior or current ipsilateral neurologic symptoms. Currently, most stroke neurologists prescribe both aspirin and clopidogrel for patients who have experienced stroke or TIA as preventive measure. The degree of stenosis appears to be the most important predictor in determining the risk for an ipsilateral stroke, and the risk of recurrent ipsilateral stroke in patients with severe carotid stenosis approaches 40%. The optimal timing of carotid intervention remains debatable, but contemporary studies showed less complications in patients undergoing carotid endarterectomy within 4 weeks after acute stroke. So the question is, what surgical intervention should be done? So there is a debate on whether or not we will do carotid endarterectomy versus angioplasty and stenting for patients. Which one is better? So the percutaneous procedure has actually become an alternative treatment for those deemed high risk for endarterectomy. There were several studies on this, um, particularly Cochrane review in 2006, which showed that carotid artery stenting had a greater procedural risk of stroke and death when compared to carotid endarterectomy. There is also a greater incidence of carotid restenosis in the stenting group versus the endarterectomy group. Another study, the CREST study, CREST means carotid revascularization endarterectomy versus stent trial, um, showed no difference between sting and endarterectomy in terms of periprocedural composite death, stroke, myocardial infarction, or ipsilateral stroke. But when further analyzed, there was a higher rate of stroke in the stenting group at 30 days and higher rate of myocardial infarction in the endarterectomy group. ICSS, or International Carotid Stenting Study, showed that stroke, death, and myocardial infarction are higher in the stenting group than in the surgical group. The current recommendation actually for the of the Society for Vascular Surgeons is that carotid endarterectomy is is to be used as a first-line treatment for most symptomatic patients with stenosis of 50 to 99% and asymptomatic patients with stenosis of 60 to 99%. Stenting is reserved only for symptomatic patients with stenosis, that's stenosis, of 50 to 99% at high risk for carotid and arterectomy for anatomic or medical reasons. Carotid artery stenting is not recommended for asymptomatic patients. The picture you see on the right shows a carotid angiogram demonstrating high-grade stenosis, as you can see here, of the left internal carotid artery. And this is followed by a stenting completion angiogram demonstrating successful carotid placement. Diba? Very nice. So this is how carotid and arterectomy is done. So the patient's neck is slightly hyperextended and turned to the contralateral side. An oblique incision is made along the anterior border of the sternocleidomastoid, centered on top of the carotid bifurcation. Vascular clamps are applied in the common carotid, external carotid, and internal carotid artery. After that, we can then open up the affected segment. The plaque is elevated from the lumen, and once removed, arteriotomy is closed either primarily or we may use a patch angioplasty, so a synthetic patch, and then we suture it to the ends. So that's it for carotid artery disease. We now proceed with abdominal aortic aneurysm, or AAA, AAA. This is the 10th leading cause of death in the US, and the incidence appears to be increasing due in part to improvements in diagnostic imaging and, more importantly, a growing elderly population. The most common location for a AAA is in the infrarenal aorta. The pathogenesis is complex and multifactorial, but the most common cause is deemed to be a degenerative process of the aortic wall. Other less common causes include inflammation, infection, and connective tissue disease. The natural history of an aortic aneurysm is to expand and rupture, and it is said that the average aggregate growth is 3 to 4 millimeters per year. So unless symptomatic or ruptured, AAA repair is actually a prophylactic repair. The rationale for recommending repair is predicated on the assumption that the risk of aneurysm rupture exceeds combined risk of death from all other causes such as cardiopulmonary disease and cancer. Triple A's are usually asymptomatic and are only found incidentally during workup for chronic back pain or from kidney stones. Rarely, patients present with back pain and or abdominal pain with a tender pulsatile mass. Patients with these symptoms must be treated as a rupture until proven otherwise. If the patient is hemodynamically stable and the aneurysm is intact, on CT scan, the patient is admitted for BP control with IV antihypertensive agents and undergoes repair usually within 12 to 24 hours, or at least during the same hospitalization. The overall mortality of AAA rupture is very high at 71 to 77%. So usually if rupture occurs at home, automatic DOA, or if it occurs or if the patient arrives at the ER, the patient is already very toxic. So prophylactic repair is best. The table shown here is the annual risk of rupture based on size. The diameter of the aorta is usually 2 to 3 centimeters, and as the size of AAA increases, we can also see that the estimated annual risk of rupture also increases. So So, abdominal aortic aneurysm is defined as a pathologic focal dilatation of the aorta that is greater than 30 millimeters, or it could be 1.5 times the adjacent diameter of the normal aorta. Preoperative evaluation should include routine history and physical examination, with particular attention to symptoms referable to the aneurysm, as well as cross-sectional imaging. CT scan remains to be the gold standard for determination of anatomic eligibility for endovascular repair. Elective repair may be done for aneurysms reaching 5.5 centimeters and above, or if the expansion rate is more than zero point 0.5 centimeters and above within 6 months, but the latter is a relative indication. The picture you see here is an abdominal aortic aneurysm. So, most likely, this is near the bifurcation na, the aortoiliac bifurcation. So, infrarenal. So, the question again is, do we do open surgery or endovascular repair? Again, let's look at the trials. The DREAM trial tells us that operative mortality rate is higher in surgery as compared to the endoluminal group, and there is also a higher frequency of pulmonary complications in the open group. We have the A1 trial, or endovascular repair 1 trial, which showed a shorter mortality at 30 days, higher in the open group versus the endoluminal group. But secondary intervention rate is higher in the endoluminal group. The OVER study, or the open versus endovascular repair study, showed a reduced perioperative mortality in the endoluminal group after 3 years, but not thereafter. And there is no significant difference in the all-cause mortality. So, based on these trials, complications are generally higher in the open surgery group, but the good side is the success rate is higher. The mode of treatment generally depends on the surgeon's preference, and a multidisciplinary approach should be done to assess the patient's comorbidities. So, surgery for AAA is basically aimed at excising the diseased aneurysmal segment, and this is followed by replacement of a graft, so as seen on the picture. So, just remove the diseased aneurysmal segment and then reanastomose using a graft. That's just basically it. It's just hard to do the open surgery because you do the abdominal approach, so you have to swing pa the intestinal contents. So next arterial disease is the mesenteric arterial disease. This is a relatively uncommon but potentially devastating condition that generally presents in patients over 60 years and is 3 times more frequent in women. Mesenteric artery disease represents 2% of the revascularization operations for atheromatous lesions. The mesenteric arterial circulation is remarkable for its rich collateral network. So, we have the celiac artery and the superior mesenteric artery, which are both suprarenal, and we also have the inferior mesenteric artery, which is infrarenal. These arteries also have abundant collateral flow, so the blood supply is quite good in this area. There are 3 major mechanisms of visceral ischemia involving the mesenteric arteries. Number 1 is acute mesenteric ischemia, which can either be embolic or thrombotic in origin. 2, chronic mesenteric ischemia, and C, non-occlusive mesenteric ischemia. Despite the variability of these syndromes, a common anatomic pathology is involved in these processes. The superior mesenteric artery is the most commonly involved vessel in acute mesenteric ischemia. Acute thrombosis occurs in patients with underlying mesenteric atherosclerosis, which typically involves the origin of the mesenteric arteries while sparing the collateral branches. In acute embolic mesenteric ischemia, the emboli typically originates from a cardiac source, and this frequently occurs in patients with atrial fibrillation or following myocardial infarction. Chronic ischemia is a functional consequence of a long-standing atherosclerotic process that involves at least two of the three mesenteric vessels. Lastly, non-occlusive mesenteric ischemia is characterized by a low flow state in otherwise normal mesenteric arteries. So the third one is common in critically ill patients on vasopressors. So arteries are normal, it's just that there is a low flow state. Clinical manifestations of acute mesenteric ischemia is abdominal pain that is out of proportion to the physical findings. There is diffuse abdominal tenderness, rebound tenderness, and rigidity, which are late signs, and these usually indicate bowel infarction and necrosis. For chronic mesenteric ischemia, clinical manifestations are more subtle due to extensive collateral development. However, when intestinal blood flow is unable to meet physiologic gastrointestinal demands, mesenteric insufficiency ensues. So, classical symptoms include postprandial abdominal pain, food fear, and weight loss. The typical patients who develop non-occlusive mesenteric ischemia is an elderly patient who has multiple comorbidities such as CHF, congestive heart failure, acute MI with cardiogenic shock, hypovolemic or hemorrhagic shock, sepsis, pancreatitis, and administration of digitalis or vasoconstrictor agents. Abdominal pain is present in only 70% of cases. So when present, the pain is usually severe, but they vary in location, character, and intensity. If there is no abdominal pain, progressive abdominal distension with acidosis may be an early sign of ischemia and impending bowel infarction. Definitive diagnosis is made by biplanar mesenteric angiography. So how do we manage mesenteric artery disease? For acute cases, of course, we do fluid resuscitation first and start systemic anticoagulation with heparin. The operative treatment is dictated by the cause of occlusion. If it is an embolus, we do aortotomy and embolus extraction. If it is a thrombus, we can do a reconstructive procedure to bypass the occlusive lesion using the saphenous vein. For necrotic bowel, there's no other option but to resect. For chronic mesenteric ischemia, the goal of treatment is to revascularize the mesenteric circulation and prevent the development of bowel infarction. So we can either do transaortic endarterectomy or a mesenteric artery bypass. Management of non-occlusive mesenteric ischemia is largely pharmacologic, with selective arterial catheterization followed by infusion of vasodilatory agents. Another arterial disease is the aortoiliac occlusive disease. The distal abdominal aorta and the iliac arteries are common sites affected by atherosclerosis. The symptoms and natural history of the atherosclerotic process affecting the aortoiliac arterial segment are influenced by the disease distribution and extent. Atherosclerotic plaques may cause clinical symptoms by restricting blood flow due to luminal obstruction or by embolizing atherosclerotic debris to the lower extremity circulation. The clinical examination of patients often have weakened femoral pulses and reduced ankle brachial index. Duplex scanning will reveal peak systolic velocity ratio of 2.5 or more, or a monophasic waveform, while MRA and CT angio may be used to determine the extent and the type of obstruction. So these are the classifications of aortoiliac occlusive disease. You can see this one in Schwartz. So type 1 is a focal disease affecting only the distal aorta and proximal common ilia. So type 2 is diffuse, but it's the disease is above the aortoiliac, above the inguinal ligament. And lastly, type 3 is multisegmental. So it can involve the aortoiliac area or the infrainguinal arterial vessels. There is no effective medical therapy for the management of aortoiliac disease, but control of risk factors may help slow progression of atherosclerosis. Patients should have hypertension, hyperlipidemia, and diabetes mellitus control. They should be advised to stop smoking. Most patients are also empirically placed on antiplatelet therapy. Surgical reconstruction may be done for severe aortoiliac occlusive diseases. So, bypass is actually common. Aortobifemoral, axillofemoral, iliofemoral, femoropefemoral, obturator, and thoracofemoral bypass. And another option is aortic and arterectomy. So these 7 procedures are usually done depending on the condition of the patient. So we shall not be discussing this further now. Um, of course, we can always do endovascular repair, but again, the choice is dependent on the extent and the severity of the disease and the patient's overall condition. Of course, if the patient is um, a high risk, very high risk to undergo surgery, then we could always opt to do an endovascular repair. But if good surgical candidate, then why not do the surgery, diba? It has a higher success rate compared to endovascular repair. So now let's move on to lower extremity arterial occlusive disease. So the symptoms are classified into two broad categories: acute limb ischemia, which occurs in 90% of cases, and they may be embolic or thrombotic, and chronic limb ischemia, which is largely due to atherosclerotic changes of the lower extremity. The diagnosis is often made based on a focus history and physical examination and is confirmed by imaging studies. The signs and symptoms of acute limb ischemia are shown here. So, what are the symptoms? We remember the 5 P's: pain, pallor, paresthesia, paralysis, and pulselessness. Some even add a 6th P, the poikilothermia, or the perishing cold, bugnaw. So that's the symptoms. So when severe, irreversible acute limb ischemia occurs when there is no more capillary return. There is already profound paralysis, profound anesthetic, and an inaudible AV Doppler finding. So for this topic, we shall only be discussing acute limb ischemia. There are actually several classification systems for the peripheral arterial disease. We have the Fontaine classification and the Rutherford classification. And we also have the Transatlantic Inter-Society Consensus classification of femoropopliteal occlusive lesions. The Rutherford and Fontaine classification here on your left are mostly based on the clinical presentation, while the task, the one on your right, is more clinically useful, and this is based on the morphologic character of the lesions. These are nice to know, but you don't really have to memorize this. Regardless of the classification, the patient with an ischemic lower extremity should be immediately anticoagulated to prevent clot propagation into the unaffected vascular bed. So, endovascular treatment is the first line treatment in patients with ALI, acute limb ischemia, since they have the potential to reduce morbidity and mortality while achieving limb salvage. Thrombolytic therapy is preferred over balloon embolectomy due to reduced endothelial trauma and potential for more gradual and complete clot lysis in branch vessels that are usually too small to access by embolectomy balloons. It is important to remember that irreversible damage to muscle tissue starts after 3 hours of ischemia and is nearly complete at 6 hours. So, time is gold. Progressive microvascular damage appears to follow rather than precede skeletal muscle tissue damage. So, the earlier the intervention, the better. Of course, there are contraindications to thrombolytic therapy. So, if you have any of these, just read it on the table, then you're not allowed an endovascular treatment. Surgical treatment may be done via embolectomy, wherein a femoral incision is done and a Fogarty balloon embolectomy catheter is used to remove the embolus. Or we can also perform a bypass graft thrombectomy, which uses vein graft or prosthetic bypasses. But prosthetic bypass is more likely to succeed. Complications of this surgery are varied and include compartment syndrome, ischemic neuropathy, muscle necrosis, recurrent thrombosis, lower leg swelling, and reperfusion syndrome, which is characterized by hypotension, hyperkalemia, myoglobinuria, and renal failure. So all are related to reperfusion of the ischemic limb and the severity and extent of ischemia. Some surgeons opt to perform fasciotomy after as a prophylaxis to prevent compartment syndrome after surgical intervention. So now we proceed to the non-atherosclerotic disorders of blood vessels. So we shall be discussing five only. There are many more sa book pero we shall not discuss them na lang. So many. So let's start with giant cell arteritis, or another term for this is temporal arteritis. Giant cell arteritis is a systemic chronic inflammatory vascular disease that typically involves the aorta and its extracranial branches, of which the superficial temporal artery is specifically affected. The clinical syndrome begins with a prodromal phase of headache, fever, malaise, and myalgias. They may have um, complications as a result of vascular narrowing and end organ ischemia, such as visual alterations, blindness, mural weakness, and even ischemic optic neuritis. The diagnostic gold standard is temporal artery biopsy, which would histologically show multinucleated giant cells with a dense perivascular inflammatory infiltrate. Treatment for giant cell arteritis is steroids. Next is Takayasu arteritis. This is a rare but well-recognized chronic inflammatory arteritis affecting the large vessels, predominantly the aorta and its main branches. Chronic vessel inflammation leads to wall thickening, fibrosis, stenosis, and thrombus formation. Symptoms are usually related to end organ ischemia, and the gold standard for diagnosis remains to be angiography, which would show a narrowing or occlusion of the entire aorta or its primary branches, as seen on the table on your right. So, naay angiographic classification depending on the occlusion, what part is occluded. So, nice to know, no need to know. Ha? No, you don't need to memorize this table. Treatment is you can give steroids, you can give cytotoxic agents for patients who do not achieve remission with steroids, and surgery, but this is only reserved for advanced stages. So, surgery here would entail just a bypass and no excision done. Next, we have PAN or polyarteritis nodosa. This is a systemic inflammatory disease process characterized by a necrotizing inflammation of medium-sized or small arteries that spares the smallest blood vessels, the arterioles and the capillaries. PAN develops subacutely with constitutional symptoms that lasts for weeks to months. Um, Intermittent low-grade fevers, malaise, weight loss, and myalgias are common presenting symptoms. There are also um, cutaneous manifestations within the deep dermis in the form of livedo reticularis, nodules, ulcerations, and digital ischemia. Skin biopsies of these lesions may be sufficient for diagnosis and may show inflammation with pleomorphic cellular infiltrates and segmental transmural necrosis, leading to aneurysm formation. Treatment is also steroids and cytotoxic agent therapy. Remission can be seen in up to 50% of patients with active PAN with high dosing. Next is Behçet's disease. This is a rare syndrome characterized by oral and genital ulcerations and ocular inflammation. This affects males predominantly in Japan and the Mediterranean. Vascular involvement is seen in 7 to 38% of patients and is localized to the abdominal aorta, femoral artery, and the pulmonary artery. The multiple true aneurysms and pseudoaneurysms may develop because of the vascular condition. Treatment is the use of systemic therapy with corticosteroids and immunosuppressive agents, which may diminish symptoms related to the inflammatory process. However, they have no effect on the rate of disease progression and arterial degeneration. Lastly, we shall tackle on Berger's disease, or another term for this is thromboangiitis obliterans. This is a progressive non-atherosclerotic segmental inflammatory disease that most often affects small and medium-sized arteries, veins, and nerves of the upper and lower extremities. The typical age range is 20 to 50 years old, but this is frequently common in male smokers. Thrombosis occurs in small to medium-sized arteries and veins, and there is associated polymorphonuclear leukocyte aggregation, microabscesses, and multinucleated giant cells. So, clinical manifestations would include foot claudication, leg or arm or hand claudication. Patients may also present with ischemic rest pain, and there may also be ulceration on the toes, feet, and fingers. Angiography may show disease confinement to the distal circulation and may show skip lesions with extensive collateralization, aptly termed the corkscrew collaterals. Treatment for this is strict smoking cessation. So, in patients who are actually able to abstain, disease remission is impressive and amputation is avoided. So, now let's go to venous diseases. So, anatomy. Veins are part of a dynamic and complex system that returns low nutrient deoxygenated blood to the heart. Venous blood flow is dependent on multiple factors such as gravity, venous valves, cardiac and respiratory cycle, blood volume, and the calf muscle and feet pumps. Alterations in the intricate balance of these factors can result in venous pathology. Veins are thin-walled, highly distensible, and collapsible, and their structure specifically supports the primary function of the veins to transport blood towards the heart and serve as a reservoir to prevent intravascular volume overload. Lower extremity veins are basically divided into three: the superficial rather, the deep, and the perforating veins. The superficial lies above the uppermost fascial layer of the leg and thigh and consists of the great saphenous vein and the small saphenous vein. The deep veins are follow the course of major arteries in the extremities. So these are the anterior tibial, posterior tibial, the peroneal veins, and so on. And the perforating veins, they traverse the deep fascia to connect the superficial and deep venous systems. They are clinically important. The clinically important perforating veins include the posterior tibial and paratibial perforators. For the upper extremity veins, similar to the lower extremity, they are also divided into deep and superficial veins. Deep veins form the palmar venous arches of the hand and empty into the radial and ulnar veins, forming the venae comitantes. The superficial veins are usually the cephalic veins, the basilic veins, and their tributaries proximal. So the evaluation of the venous system begins with a detailed history, physical examination, with imaging studies. So when there are venous pathologies, we usually see varicose veins, the one shown here, hyperpigmentation, such as this one, the middle picture, and venous ulcerations, such as the one on the far right. So let's tackle venous thromboembolism. The incidence is approximately 100 per 100,000 people per year. And there are three broadly stated conditions described by Rudolf Virchow in 1862, the Virchow triad, that contribute to VTE formation. So this is stasis of blood flow, endothelial damage, and hypercoagulability. Of these risk factors, relative hypercoagulability appears most important in cases of spontaneous VTE or the so-called idiopathic VTE, whereas the stasis of blood flow and endothelial damage likely play a greater role in secondary VTE or the so-called provoked VTE, occurring in association with transient risk factors such as immobilization, surgical procedures, and trauma. Preoperative VTE risk assessment is becoming increasingly common to identify patients at moderate and high risk. So the table here lists the level of risk for patients who shall undergo surgery and the suggested thromboprophylaxis measures. Those at moderate and high risk generally require medical management, while low risk patients may only require thromboembolic stockings. Duplex ultrasound is the most commonly performed test for detection of infrainguinal DVT with a sensitivity and specificity of greater than 95%. The goals of treatment are the prevention of mortality and morbidity associated with pulmonary embolism, as well as prevention of post thrombotic syndrome. The table on your right shows the recommendations for antithrombotic therapy for DVT. So essentially, we use vitamin K antagonist or a low molecular weight heparin for 3 months, or they may be extended as needed. Other treatment options for VTE are the placement of temporary or permanent vena cava filters. They are used as preventive measures for pulmonary embolism and are indicated for patients who have manifestations of lower extremity VTE and absolute contraindications to anticoagulation, or those who have recurrent DVT despite anticoagulation therapy. Systemic thrombolysis potentially reduces acute congestive lower extremity symptoms more rapidly than anticoagulation alone and decreases post-thrombotic syndrome. Operative thrombectomy is generally reserved for patients who have worsened with anticoagulation therapy and those with impending venous gangrene. So we have other venous thrombotic disorders such as superficial vein thrombophlebitis. They occur in varicose veins, but they can also occur in normal veins. We have what we call a thrombophlebitis migrans. This occurs when the SVT recurs at variable sites in normal superficial veins. This may signify a hidden visceral malignancy or a systemic disorder such as blood dyscrasia. Clinical signs include redness, warmth, and tenderness along the distribution of the affected veins. Duplex ultrasonography confirms diagnosis, and treatment is NSAIDs and low molecular heparin. Mesenteric vein thrombosis causes acute mesenteric ischemia in 5 to 15% of cases. Mortality rates may reach as high as 50%. The presentation includes nausea, vomiting, and diarrhea, and diagnosis is made through CT or MR angiography. Treatment for these patients include fluid resuscitation, heparin anticoagulation, and bowel rest. Laparotomy is indicated only in patients with peritoneal findings. Next, we shall tackle on varicose veins. These are common and are present in 10% of the general population. They are dilated and tortuous veins. There may be telangiectasia and fine reticular varicosities. Risk factors include obesity, female sex, inactivity, and family history. Two types of varicose veins occur. One is primary, which result from intrinsic abnormalities of the venous wall, and secondary varicose veins are those that are associated with deep and or superficial venous insufficiency. So patients may complain of an unsightly appearance, there is aching, heaviness, pruritus, and early fatigue of the affected leg. So with prolonged standing and sitting, the symptoms may worsen, and they're only relieved by elevation of the leg above the level of the treatment is basically conservative, um, mostly elastic compression stockings. This must cover the symptomatic varices. So the compression stockings are varied. They come in different unsa na kanang pressures ba. So from 20 millimeters mercury up to 50 millimeters mercury. So it can be knee high, it can be thigh high, some can even reach the hip. So it depends on the use of the patient. Sclerotherapy provides significant symptom relief and improve cosmetic appearance. So the sclerotherapy acts by destroying the venous endothelium. Sclerosing agents used include hypertonic saline, sodium tetradecyl sulfate, and polidocanol. Thermal ablation is generally associated with equally effective but a more rapid post-procedure recovery. And surgery is done through saphenous vein ligation and venous stripping, especially for patients with um, great saphenous veins of a very large diameter, usually 2 centimeters or more. Large varicose veins are best treated by stab avulsion technique, wherein we make 2 millimeter incisions directly over the branch varicosities, and the varicosity is dissected from the surrounding subcutaneous tissue as far proximally and distally as possible through these small incisions. So, last topic, chronic venous insufficiency. This affects around 600,000 people in the US, and symptoms include leg fatigue, discomfort, and heaviness. Patients may present with signs of varicose veins, pigmentation, lipodermatosclerosis, and venous ulceration. Chronic venous insufficiency can be primary or secondary. Primary CVI results from intrinsic abnormalities of the vein wall, whereas secondary CVI, the so-called post-thrombotic syndrome, occurs as a result of DVT or deep vein thrombosis. The signs and symptoms of CVI can therefore be attributed to venous reflux, venous obstruction, calf muscle pump dysfunction, or a combination of these factors, as well as loss of venous wall elasticity. Venous duplex ultrasound has become the gold standard for evaluation of venous function, largely supplanting venography and plethysmography. Non-operative treatment for CVI is compression therapy. This is actually the main stage of treatment. Compression can be achieved using a variety of techniques, including elastic compression stockings, paste gauze boots or UNAS boots, multi-layer elastic wraps or dressings, and pneumatic compression devices. So the pictures you see on your screen are the techniques for compression therapy. So the left one uses a multi-layer dressing, and the one on the right uses Velcro. Other options for treatment of CVI include skin substitutes. These are commercially available or under clinical study in the US, but not yet available here in the Philippines. There is a skin substitute called Apligraft, which is a bilayered living skin construct. It is said that it provides faster healing as compared to compression therapy alone. Healing occurs now within 6 months, whereas compression therapy greater than 6 months ang healing. So lastly, surgical intervention can be done. Um, the incompetence of the perforating vein connecting the superficial and deep venous system has been implicated in the development of venous ulcers. So the SEPS procedure is an endoscopic procedure to locate the perforator veins and ligate them. However, its efficacy is controversial and still unproven. Currently, it is accepted that superficial venous surgery, in addition to compression therapy, has a role in the treatment of patients with venous ulcer. Other surgical interventions mentioned in the book are deep venous valvular reconstruction and venous stenting, both of which are still under study. That ends our topic for this afternoon. So let's just review. You can ask me questions anytime. Just ping me. Thank you for listening.